The Institute of World Affairs at the University of Wisconsin-Milwaukee presents International Focus, a weekly discussion of the people and events behind today's global headlines. Support provided by Milwaukee Public Television and the UWM Center for International Education. Now here's your host, Doug Savage.
Welcome to International Focus. In its 1945 election manifesto, the British Labour Party proclaimed, quote, "Much avoidable ill health can be prevented. The best health services should be available free for all. Money must no longer be the passport to better treatment," close quotes. Well, although much amended, the British National Health Service grew from this principle. In the UK and other industrialized nations, healthcare systems may seem at first glance to be based on a fundamentally different model than the US. Yet governments everywhere must deal with the same three key variables when providing their citizens with care: access, quality, and cost. As the dust begins to settle on the rollout of the Affordable Care Act, our guest today will help us explore similarities and differences between various national health care systems and offer a prognosis on American care going forward. Susan Giaimo is professor of political science and health policy at Marquette University and author of the book, Markets and Medicine, The Politics of Healthcare Reform in Britain, Germany, and the United States. Susan, welcome to International Focus.
Thank you.
Well, I'd like to start with a quote from one of our legislators. This is Senator Jeff Sessions, a Republican from Alabama, in discussions regarding the Affordable Care Act, said, quote, "Obamacare is destroying the greatest healthcare system the world has ever known." So, first of all, do we have the greatest healthcare system the world has ever known?
No, I would say no. We have the most expensive one, but it's not great by measures of access, quality, or cost. We have 17% of our population goes without health insurance. We have the highest cost in the world. We're spending more than $8,000 per person on health care, and the OECD average is about $3,600 per person. And our quality indicators are not very good, whether you measure it as infant mortality, life expectancy, or years of healthy life before the onset of debilitating disabilities from old age. We don't do very well at all. We rank in the middle in a lot of of our peer countries on those measures.
Well, if we take a step back, then, if it's not the greatest healthcare system on earth, is it in fact a healthcare system at all? Do we have a coherent system?
Well, I think a lot of people would call it just a non-system or a patchwork, and it's started out as mainly private employment-based insurance, and then government programs have been added on over the years, particularly starting in the 1960s with Medicare and Medicaid for people outside the labor force. But there were a lot of holes in that safety net, and they've grown bigger as employment-based insurance has shrunk. And so I think it was really getting to the point where the system was going to implode if we didn't have something like the Affordable Care Act to really shore up employment-based insurance.
Well, let's dig a little deeper into some of those indicators. Bloomberg did a study recently in which 48 countries were surveyed for just the efficiency of their healthcare systems, and the U.S. ranked 46th ahead of Serbia and Brazil, worse than China, worse than Algeria, worse than Iran. Give you some sense of some of those indices we were talking about. Hong Kong came in at number 1. Life expectancy, something in excess of 83 years. For the U.S., it's 78. So we lose 5 years there. They spend 3.8% of their GDP on health care. We spend, as you mentioned, 17. And the per capita spending is about $1,400 there versus something, as you mentioned earlier, slightly larger than 8,000. So how is it that these other nations seem to have gotten it better than we have?
Well, I think what they've done a number of things, and one of the things they've done for solving the financial barriers to healthcare is making sure that everybody's insured, whether it be a single payer model like Britain's or Canada's or multiple insurers like Germany or the Netherlands or Switzerland, everybody has to be insured, and everybody pitches in, and that's employers, employees making payroll contributions in the national health insurance systems of Germany, and also in the single payer systems, it's tax financed, and so everybody is covered, and you get health care in these countries on the basis of your need rather than how deep your financial pockets are. So that solves the access problem, and then government subsidizes the costs of health care for those who are on lower incomes, whether it be through less payment of taxes in the single payer models or subsidies for insurance, for employment-based insurance or individual insurance as in Switzerland. So that's a big plus right there, is one big point is solving the access problem by having everyone in. But they've also realized that having everyone insured saves money and is cost effective because unlike the United States, where we have a lot of people uninsured who wait till they're really sick before they seek medical treatment and then end up in the hospital emergency room or in a hospital stay, which is the most expensive setting for care, these countries have much more timely access and regular access to primary and preventive care. So I think it makes sense.
You treat the cold rather than pneumonia that follows.
Exactly. So that's another realization that they have. But then the other thing that they do in terms of managing costs is making sure that they really are careful on the supply side. So whereas in the United States, we basically limit access to care by ability to pay and what kind of health insurance you've had, in these other countries, they do more on the supply side. So they have a better balance between primary care and specialty care. So it's very typical in Europe and in Canada for the mix between specialists and primary care providers to be about 50-50. Whereas here we have 2/3 of our physicians are specialists and only 1/3 are primary care. So we tend to overemphasize very, very high-tech, invasive, specialized care. They also pay doctors and providers differently. They, in many European countries, they either pay hospitals a global budget or they've borrowed an American invention for Medicare and they pay a lump sum per diagnosis, what is known as diagnosis-related group, or DRG. Or they may pay a flat rate, a flat fee for an episode of care, like the costs associated with treating a hernia, for example. Physicians, too, are paid differently. They, unlike the United States, where we have pretty much unrestricted fee-for-service, which is really piecework, and doctors are rewarded financially for doing greater volume of more expensive services and more invasive procedures. These other countries either put doctors on salary or capitation, which is a fixed amount per month to the physician for all the members, all the patients enrolled in his practice or her practice. Or it may be fee-for-service, but it's restricted to a single fee schedule, and in Germany the doctors live within a cap. So they have so much budgeted for ambulatory office-based care in the year, they get paid fee-for-service, and if they start hitting that ceiling at the end of the year, they get less per service.
Well, you touched on this a little bit, but talk a little bit about how our system, if we have a system, evolved over the history of our society.
Sure. Well, it was really accidental, and I think one thing led to another, and it started pretty much in the Depression with the creation of Blue Cross and Blue Shield, which was the health insurance for hospitals and physician services started by these providers to ensure they had a regular income stream during the Depression. And then it spread to employers, and one of the ways it became entrenched was during the Second World War, during a period of wage and price controls. The government basically said that employers couldn't bid up wages and offer more wages, but they could offer fringe benefits as a way to attract and retain scarce workers during this wartime economy. So that's what they did. And then after the war, the National Labor Relations Board ruled that labor unions could bargain things like fringe benefits, including health insurance, and not just wages. So that's the way it became entrenched, and it became much more widespread. It was mainly then employment-based insurance for the larger firms provided by nonprofit insurers. And then there was a realization, obviously, that there were certain groups outside the labor market who needed assistance and needed health care, and that was senior citizens and the poor and the disabled. So in the 1965, the United States federal government basically introduced Medicare and Medicaid.
So I'd like to read another quote if I could, and this is Michael Tanner, who's writing for the Cato Institute, who has a certain political take on all of this. And he says, quote, "The answer to America's healthcare problems lies not in heading down the road to national health care, but in learning from the experiences of other countries, which demonstrates the failure of centralized command and control and the benefits of increasing consumer incentives and choice."
Well, I think that's a very, very out of date and maybe exaggerated model of what national health insurance looks like in other countries. There are systems where the government basically owns the hospitals, has physicians on salary, as in Britain, and the healthcare budget is set centrally and administered out of London. That is much more of, I think, a top-down model of government control, if you will. But even within that model, there's been choice and competition among providers for patients. I think what's more interesting is that other countries, the model is much more the national health insurance model, where there are multiple insurers offering insurance to people, either through employment or as individuals. And there's competition and choice among insurers and providers. And that's what we see in Germany and the Netherlands. And they have basically decided that competition and choice can spur efficiency, but it has to be regulated. There have to be rules on the competition so that competition is fair, because otherwise insurers will end up just competing for healthy risks, signing up healthy people and shunning the sick, which is what happened in the United States with the entry of for-profit commercial insurers who played by those rules and undercut the community rating, the common premiums that were set by the nonprofit Blue Cross and Blue Shield. So in fact, there is quite a lot of competition and choice in these other systems, and it's not all top-down government run.
Right, and even within those systems, you touched on this. It's an evolving process, is it not? I mean, it's not a single piece of legislation doesn't sort of set it in stone forever.
Sure, and I think these systems have evolved, and if one looks at, say, the Netherlands or Germany, they're constantly tinkering, constantly innovating, and it takes a while for things to percolate through because they have to basically make sure the political parties can agree and the various stakeholders in the healthcare system. But it's a constant innovative process. And even I think if you look at the United States, Medicare doesn't look exactly the way it did when it was enacted in 1965. There have been expansions in terms of coverage and same with Medicaid. So I think to expect that one law is going to solve all the problems is really unrealistic.
Well, we're going to take a short break, but when we come back, you touched on some of the various places and various models we could be looking at, and we'll go into a little greater detail about some of the broad models that are out there. But first, we'll take a short break.
The Institute of World Affairs presents our community with a range of public programs relating to global issues, U.S. foreign policy, and the world economy. For more information about the Institute of World Affairs, call 414-229-3220 or visit our website at www.iwa.uwm.edu.
Welcome back to International Focus. We're examining healthcare systems around the world with Susan Giaimo. Well, before the break, we talked a little bit about what's in place in other places. So let's kind of go model by model, if you will, starting with UK and sort of similar to some of the systems we see in Scandinavia, Spain, single payer. Tell us about that.
Right. Those systems basically have only one payer, which is the government. And it's financed mainly out of progressive income taxes or sales taxes as well. And in those systems, people everyone is in the risk pool. Everyone's covered under that insurance model, and it's basically healthcare according to need rather than ability to pay. In a lot of situations, doctors and hospitals are government entities. They may be on salaried employees to the government, or the government may own the clinics. But even there, even within this model, there's a lot of variety. I think the British model has tended to be the most centralized. In Sweden, it's much more decentralized down to the level of the counties. The counties basically collect the taxes and administer and design a lot of the services. So it's not as centralized as some people might think.
Well, and the individual citizen really doesn't have to do much to be connected to the system then, right?
Right. Everybody's in, and you don't have a lot of different insurers to get authorization through. It's much administratively simpler. The government has a lot more cost containment control because it's the only negotiator, it's the only payer, and so it has some clout in negotiations with providers. Some of these systems, however, do such a good job of containing their costs and limiting the budgets that they end up with waiting lists for non-emergency services and elective services. And so then people are put on a list based on their need.
Right. So this is the sort of downside you hear by people who are
Right.
disquieted by such a system, that grandma will have to wait for her knee replacement for who knows how long.
Right, and what happens in these systems is they're responsive to voters, so that if the voters are upset about if the waiting lists are getting long, they let the politicians know about it, and they hear about it, and they complain, and providers complain, and then the governments will become more responsive and then raise taxes or spend more or find ways to devote more money to healthcare. But because it's just part of one budget nationally, say as in Britain, healthcare is competing with things like education, defense, policing, other things. And so I think in other systems, though, they spend more and they have much more, I think, responsiveness lower down.
Well, let's look at sort of a different model, something you might find in Germany, France, Japan, to a lesser extent, and there you have a multi-payer system, right?
Right. So there you have people can choose their insurer from among a couple of hundred nonprofit insurers. In Germany, there are about 190 health insurers that people can choose from, and that provide a basic benefits package, but might provide additional benefits if people are willing to pay extra for that. And they're competing for people's business, basically, for patients on the basis of offering good services, lower costs, good customer service, that sort of thing. But they can't compete by only choosing healthier people and turning away the sick. Everybody's in, everybody is covered, but people have that choice. And then providers are mixed. So there may be some government-run hospitals, particularly at the local level, but most doctors are private and private entrepreneurs, and they may be paid fee-for-service within a cap, as I said earlier, or hospital doctors are on salary and are salaried through the hospitals that they work for. But again, the system is much more decentralized. Germany has a federal political system like ours, so it's really each state that determines, say, at each state that's the administration, and it's not even the state government per se. In the German system and in a lot of these other countries, they basically allow the medical associations at each state level, working with the insurers associations at that level and hospitals at that level, in their associations negotiating fees and the terms of service. And so the government might basically set out the general parameters of the system, that everyone has to be covered and everyone has to have access to medically necessary care, but the actual determination of what is medically necessary and how much that's going to be is negotiated by the providers and the insurers. So it's the stakeholders basically who run it.
So how does that change the business model? I mean, we have insurance providers, private sector insurance providers in the American system and in a system like this. How does their business model differ?
Well, I mean, I think health insurers here are now going to have to move back to that, and that they're going to have to compete for people on good customer service, on getting more cost-effective and clinically effective services out of providers, and delivering and offering lower premiums that way. but they're not going to be able to just do what they had been doing, which is denying coverage to people with pre-existing medical conditions and denying coverage to people who are sick or charging them astronomically high premiums. So in these other systems, these insurers and providers compete to survive, but they compete fairly on these other things like customer service and quality of service and that sort of thing, and lower premiums rather than just cream skimming.
And then let's move closer to home, Canada and a national health insurance scheme.
Right, there it's single payer in the sense that each province is the sole payer of health care, and that is financed again by taxes, income taxes, sales tax, and a mix of other taxes, and that's the sole payer, the sole insurance that people have. Doctors are paid fee-for-service, and they negotiate a fee schedule with the provincial government through their provincial medical association, and hospitals are on global budgets.
So then we said at the outset, sort of the three parts of the equation are access, quality, and cost. Talk a little bit about how each of these addresses those three, if you would.
Sure. I think in the single-payer models like Britain or Canada's, if you are feeling having a life-threatening emergency and need immediate care, there's no question you don't wait. But since there are fixed budgets for health care, there is waiting lists to determine who's going to get access to the non-life-threatening elective surgeries. And in some cases, they can go pretty long. It depends on how much the government is willing to spend on health care, which again is a function of how much taxpayers are willing to pay. But people, I think, generally think this is, in those countries, agree to that because they feel that everyone's treated the same. So you are getting good quality care when you need it, but you might be waiting for some of the non-life-threatening measures of non-life-threatening services. The other systems are a little less cost-effective. There's, with the systems with multiple insurers, there are more insurers, somewhat higher administrative costs, but they are able to keep costs down by having unified negotiations with providers. So all the insurers negotiate together in a particular state in Germany, so that they're not being undercut and outbid in order to get physicians or hospitals' business. And the quality indicators are quite good there, and there are no waiting lists except for organ transplants. So the waiting list that people say is a feature of universal coverage is not true in every system. That's not the case in these national health insurance systems of Germany and Switzerland. But they also spend more on healthcare than, say, Britain. Again, though, they're spending less than about half as much as we do, and they're covering everybody, and their quality is good.
You know, you mentioned efficiencies. Taiwan actually typically scores quite high, and one of the factors they point to is the smart card that patients get, where basically their charts are in a little chip and they carry it with them. So what is the role in terms of cost of just those kinds of administrative paperwork inefficiencies? That's
a lot. And in this system, in the United States, we spend an awful lot on duplication of services and lack of coordinated care and paper shuffling because we have multiple insurers with different forms, different procedures, different requirements and pre-authorizations. There's an awful lot spent on administration here. It's typically about 11% of the premium dollar. In these other systems, even with multiple insurers, it's typically more like 5%. So we do spend a lot on administration. We're moving away from that by adopting electronic medical records, which will help coordinate care and do a much better job, I think, eliminating some of this top-heavy private bureaucracy, essentially, which is what we have in this country.
So we've just got a few minutes left before we go. What, in the current iteration of the Affordable Care Act, which direction of these models that we've talked about would you say we've moved closer to, or certainly moving toward?
I think we're moving quite close to the national health insurance model of Germany, where it's largely employment-based, and employers contribute, just as larger employers are expected to here. And then, but there's also an individual mandate for people who are self-employed, and government subsidies for people's insurance premiums that way. But it's the same idea of multiple insurers competing for patients. Everybody's paying in. The employers are also paying in. I think we're on a tentative, maybe ambivalent step toward a national health insurance model that way, and with largely private providers and private insurers. And I think that's where we're moving, and we're also moving with in step with other European countries to try to figure out what works both from a clinical and cost-effective standpoint, so that you get better value for money. Not that you deny care to people, but you figure out what treatments actually work, and it's called comparative effectiveness research. Germany and Britain are doing it, and now the United States is starting to experiment with that too.
Well, and as you say, it's an evolving process. We'll keep an eye on it. Susan Giaimo, thank you for being with us. To our viewers, we'll see you next time on International Focus.
For information about the Institute of World Affairs and its many programs, or to become a member of the Institute, call 414-229-3220 or visit us at our website,